Welcome to you, Greg. And I've invited Greg because we're going to talk about the subject of treating and helping athletes recover. And Greg is an experienced physiotherapist from New Zealand, but I'm quite sure that Greg would prefer to present himself and his bio and his clinical background, because I haven't really digged down into details. But I can tell you this much. I've heard and I've known about Greg, and I've talked with Greg for the last 14, 15 years, something like that, during our common interest in what we call mechanical diagnosis and therapy. But Greg, could you please give the listeners a bio and tell us a bit about your clinical experience?
Yeah, sure. Thanks, Brian, and thanks for the invite for speaking on this podcast. So, as you mentioned, I'm a physiotherapist from New Zealand. I graduated 30 years ago now, so I've been around a wee while, and throughout that time, I've looked at completing the diploma in mechanical diagnosis and therapy earlier on in my career, as well as a diploma in manipulative therapy and postgraduate certificate in rehabilitation. I've been a Mackenzie Institute faculty member for the last 16, 17 years, and currently on the Mackenzie Institute Education Council and Board of Trustees from a governance perspective. Within New Zealand, I have a couple of private practice clinics, and also I work with a group called High Performance Sport New Zealand, who are an organisation that work with Commonwealth Games, Olympic Games athletes and World Championship athletes. So that's sort of in my spare time, I work with that group and dealing with some of those athletes. So reasonably busy in terms of private practice. So I'm still very much a clinician at heart, but I also have some other roles in terms of some governance duties to look at as well.
So how long have you been experienced with working with athletes, Greg? Did that start when you started in clinical practice, or is that something that's come on because you have a certain interest in that group of people?
Yeah, good question. No, very much. Initially, I worked with the Mackenzie Institute actually on a chronic back pain program, and that lasted for about 3 or 4 years. And so really in my earlier years, I was only treating chronic low back and neck pain. And then when that research project finished, I went into private practice at that stage and really only got involved with athletes because of my kids and their sport that they were doing. And I would be sitting on the side of the field or the court or the pool deck and talking to other parents and other coaches, and started to see some of their kids. And then those kids grew up into athletes themselves, and working with those people and the coaches, and then graduating up into the different levels of athlete performance. It sort of morphed into this dealing with more athletes. So it was very much a sort of fell into the position with dealing with athletes from really watching my kids and observing my kids and standing on the side of the court.
Okay. So contrary to me, you wasn't the young physio that went into physio school because you've been an athlete prior to that, and then you wanted to work with athletes. That's definitely not your story. That was my story.
No, not at all. No, I've always been interested in sport, like most Kiwis are. I was always a weekend warrior. I was never a talented athlete. I always had the aspirations to be a talented athlete, but it wasn't in my genes. So I've always been a weekend warrior. But loved watching my kids, and particularly my son, who is a regionally talented swimmer, and that sort of started it. So he was involved in swimming, and we were going along to the pool sort of 8 to 9 times a week in terms of the level that he got to. And so that meant a lot of time spent on the side of the pool deck, talking to parents and talking to coaches. And so I would start to see some of the older swimmers as well. And through that, it meant that I started to see other athletes from other sports as well, just because of the involvement within that level. So no, it very much graduated into becoming a physiotherapist working with athletes. It wasn't something that started straight from the beginning.
No. Yeah, I think it's been a bit on and off for me. I was a decent swimmer, and when you said genes, I don't have the genes to be a decent swimmer. So I guess I've just worked a bit harder to become somehow decent.
Yeah, well done. There's those kids who are always deemed to excel later in life, and then there's those ones like us who just try as hard as we can.
Yeah, exactly. So when working with athletes, is there anything? They're human beings like you and I, and they have their lived experience, and they have they have issues, which is why we see them and stuff like that. Is there anything particular, anything special when you're meeting up with an athlete in your first consultation, Greg?
Yeah, I actually think you cover that quite nicely. They are human beings. They are like us. They have emotions. They have baggage that is going on. They have stresses in life outside of their sport, and we'll come to that a little bit later, because I think that's important to recognize and acknowledge also, is that other side of it. It's not just what you're seeing them doing in the gym or training or with their team or whatever, that they also have a life outside of their sport, and that's something that we need to acknowledge also. And I think we'll come to that a little bit later. So if I've got an athlete that I'm seeing for the first time, I really want to get a good understanding around that athlete. So what are the reasons why they are approaching you in terms of coming to the clinic? Is it because they've got a current injury? Is it because they've got a recurring complaint? Is it to potentially look at performance enhancement in terms of, can we improve them in terms of maybe strength or flexibility or something to improve their performance? So really getting a good understanding of why are they coming to see you, and also what are their expectations from them coming to see you. Is it, are they looking at an assessment of them and how they move and how they perform, this type of thing? Are you dealing with an acute or chronic injury or recurring injury? So, and what are their expectations around that, and what are their expectations around their potential management of their particular problem? So I think that's a really important thing. The thing I do want to know from any athlete is, what have they been doing in terms of training? So what does their training involve in terms of potentially gym work, potentially specific sport-specific type activities? What does their training load involve? And I want to know from a daily perspective, a weekly perspective, and a monthly perspective, what have they been doing? What are they currently doing? And what are their goals and aspirations? So have they got an event coming up? Have they got competition coming up? What is in the pipeline for the future? And I think those aspects are really important to gauge, so that you have an understanding of what are they working with in their current load, in terms of weights, in terms of running, in terms of swimming, whatever they're doing. Get a good understanding of what that involves, because that ultimately will dictate a little bit around the management that you're doing with the athlete. And then, as you alluded to, what else is involved with that athlete? So what other support network may they have? Their involvement with their coach. Do they have a strength and conditioning trainer? Do they have a nutritionist, a massage therapist? What other support network is there? Do they have family? Do they have friends? Do they have parents that are involved with them as well? And a little bit about their social life. So you get a good understanding of what they're doing in terms of their sport, but also the bigger picture in terms of the person in front of you and all the stresses that may be involved. We've had situations where we've got athletes who are professional, and they are covered from a financial perspective and have everything laid on the table for them, versus those people who are more social, semi-professional, or more weekend warriors, where they don't have that support network and all the stresses that may be involved. So there's lots of aspects that we'll want to know about the athlete that involves both their sport, but also their social life and them as a person. And I think that's really important to have that understanding, because you need to build up that rapport with that individual, and to have that broader understanding of them is really important.
Yeah. I think you're saying so many things that I can relate to, and I think it's quite important. And I also think sometimes if we kind of ask the question, what are the short-term goals and what are the long-term goals? Do they need to compete while we're working with them? Let's say they have an injury, or don't we have a competition within the next 3 months? Because that could also be a stressor. And what are their coaches and peers telling them in regards to the goals they're having?
Yeah,
and
absolutely.
sometimes I also think, Greg, that they come to us on their own, or do they come to us because they've tried tons of other things, or do they come to us because their coach have heard something, so they actually don't want to go to us, but the coach are kind of saying, you need to see this guy or this girl?
Yeah, and all those different aspects are really important to acknowledge and to have that understanding of, because it does sort of alter the way that you may converse with the athlete, how you manage the athlete, how you work together as a team. So bringing all those different aspects into it, and it may be something that we need to bring the coach or the strength conditioning trainer or support network in, so that you're all working off the same page, and having that broader understanding of all those different aspects when working with the athlete. And as you alluded there, getting to know what is happening in terms of their current training, but also competition. So as you say, are they in season at the moment, and how are we going to work with them during the season, taking in consideration their training and competition and whatever they're doing, whatever sport that they're doing? Or are they out of season, and in which case your management may differ quite a bit if they're out of season and they haven't got a race or an event or a game in the next few days. So all those aspects are really important.
Yeah. And then I think there's also some kind of the more we do this, the more we gain their trust in most people, because we show an interest.
Yeah, that's right.
And then again, we can also show an interest by really wanting to know more about the demands of the sport.
Yeah, absolutely. And that may be something that if you don't, as a clinician, if you don't have a good understanding of the individual sport and those demands, it's really important to go to the field or the court or the pool or wherever they're training and observe what's happening, talk to the coaches about what's happening. I look at myself in terms of being involved with the swimmers, and I once had a person say to me when they saw me swimming that I looked more like someone in a washing machine, with my arms going everywhere and hands and legs going everywhere, and that's not the sort of swimming style that would take me to a podium position. And so I needed to have a better understanding of what swimmers do. And so I stood on the pool deck, and we videoed, we slowed down the video of the swimmers. We looked over the water, under the water, looked at their turns through the pool, all these different technical aspects. So I had a better gauge of what was happening with the athlete as they were doing their sport. And I think that's really important. So no matter what sport you're looking at, you need to have that, as I say, that understanding of the sport, the technical side of it, which may happen in the management.
Yeah, because you kind of, what I often experience with working with athletes, it's actually the same with everybody else, but it's just at a different and a higher level. You're helping those people like navigate in their load lots of the time. And that's also why we're interested in hearing what their load are every day, every week, every month, and maybe even going a year back.
Yeah, that's right. And
you can help them navigate, and you can't bring a person back to their sport if you don't know the demands of the sport.
no, that's right. That's right. And there's so many variables with that as well. So you've got people like swimmers or runners or cyclists who are doing a repetitive motion so often with that one particular stroke or style or whatever they're doing. So if we take swimmers, you know, in a session, they may be doing 6,000 strokes in a session, which equates to around about 2 million strokes a year. So you think of the load, the repetitive motion that they're doing, versus someone who's playing maybe football or rugby union or something, which is much more of a varied type of load that they're doing. They're not doing a specific repetitive motion so often. I think, you know, at the moment we're watching the Olympics and looking at all the different sports that are involved, from the running to the shooting to the judo to the diving, rowing, canoeing, you know, the rugby sevens. You know, there's so many different athletes and so many different sports that all require different demands, that as a clinician, if you're dealing with someone, an athlete involved with any of those, you need to have that understanding of those demands, the mechanical load, and everything else that goes on with those athletes.
Yeah. So when you see an athlete, a couple of years ago, it was very there was a short trend in Denmark that everybody had to do an FMS test. Do you know what that is? Kind of functional movement screen.
Yes.
Luckily, from my perspective, it kind of faded out again. And if you look at the data, that makes sense. And then we film our clients and stuff like. Do you use assessments like that when you're seeing an athlete? And how much do you trust the way they're moving compared to how much do you value the pattern of movements and your inspection and stuff like that, compared to how much you value what they're telling you and what you're finding with just listening to their load?
Sure. I think that brings up probably two different aspects. One is those functional movement screening or biomechanical screening. They really came around to see if we could predict those people who are possibly predisposed to future injury.
Yeah.
And that was the main reason that they were around. And I think research has shown us evidence that it's very difficult to predict those who are predisposed to injury. And I think the FMS testing and these sort of movement screening have been shown not to be reliable in terms of predicting those who may have future injuries. So I think we've got to be cognizant around not putting too much emphasis on that type of screening with an athlete in terms of trying to identify those who may be predisposed to injury. So I think that's one component. I think we need to be wary about that. In saying that, I am interested in the way that athletes move and what they're doing. So if I've got someone who's had a chronic patellar tendinopathy or an Achilles tendinopathy, then I will be interested to see how are they squatting, what's their single knee bend, single leg squat like, what is their calf endurance like, what are they like with hopping, jumping, landing, you know, these sort of things I will want to know and observe what I'm seeing with them. You know, if I see someone with a patellar tendinopathy who doesn't want to hop because of pain, or they've got some strength deficit that's affecting them, then I will want to know that and observe that. And you're looking at that broader picture. So I'll certainly go through a screening process with the athletes, looking at that type of thing, but more in relation to how is this affecting their condition? Are they showing fear avoidant behavior with certain movements? Are there possible strength deficits that may be contributing to their complaint? So, you know, I certainly will go through a screening type process in terms of whether it's lower limb or upper limb to get a better understanding of what's happening. So, yep, I certainly will look at that more functional movement to see, does it give me any more information with regards to their complaint.
Would you go as far as changing a movement pattern? If you look somebody movement, or if you looked at, no, let's stay with the movement pattern. Let's say you have an athlete that's competing at the Olympics at a, what would that be? It'd probably be like 1,500 meter around the athletic stadium. Would you be worried about the way they were moving if they were injured? Let's say this was the first time they had this injury.
I would look at it from two perspectives. One is, if this is a new injury and they're an elite athlete and they've managed to get to that status, that level, with the current movement pattern that they do, then the last thing you want to do is to change any style or technique, any movement that they're doing. They've got to that level with their body type. And I think we need to, recognize that everyone moves differently. And if this is a new injury and they've managed to get to the level that they've got to with their movement pattern, then I'm not going to change that whatsoever. We've seen many athletes, I think in the last Olympics, with the female marathon winner, who, you look at her mechanics of running and you would never think that she would be at the level that she got to, and yet she won Olympic gold. You see many athletes who have different ways of moving, but move really well and function really well, and don't have injuries. So I certainly wouldn't look to alter it. If I've had an athlete who has had a recurring injury and there's potentially alterations in their movement pattern that you may think is contributing to their recurring injury, then I'll certainly discuss it with the athlete, but also their coach and their strength and conditioning trainer, and see, do they think that this could be contributing to it? So I think you've got to look at it, working with the athlete and their support network to see, is this something that should be modified? Is it something that could be predisposing to their recurring injury? And I think that's where we need to sort of look at it from that perspective.
Yeah. Yeah, I wouldn't be that keen on changing things. Just, I think I'm thinking a bit like you are. And then I think if I change something, I might just change it as well, not to do it permanently, but maybe just to unload the way they're moving for a period of time.
Yeah. And that may be something that we need to.
Yeah, and then not worry too much of what they're doing when they don't have the pain.
Yeah. I think we've evolved way past that feeling that there is a norm that everyone needs to comply to.
Yeah.
I can't recall the last time I saw someone that fitted within that norm. Most of the athletes that I see have got to that level because they have something unusual about their body that is not within the norm, but that is why they've got to the level that they've got to.
Yeah.
It may be with a swimmer that they've got this incredible flexibility that allows them to achieve what they're doing.
Yeah.
So yeah, I'm very hesitant to change anything. And if I was to change anything or recommend changing something, you'd have to really validate the reasons for that and work with the coach and the athlete around, why are we potentially looking at this? And it would really only be with those athletes who have a recurring injury of the same thing that you're thinking, right, maybe this movement pattern is having an effect on their recurring injury.
Yeah, and I also think we talked about the human before, Greg. There could be a downside of starting to telling people that they're moving the wrong way.
Yeah, absolutely.
It would be, I mean, if you're a top athlete or just if you're a weekend warrior, like there's actually the definition of just being an athlete. I think it's just that you want to compete. And spend
that's right.
2 to 4 hours a week working out in some kind of sports. But I think that when they start, sometimes they can lose confidence on their movement, on their body, which they have to trust in a very stressed situation. So I think we can trust the data when it tells us that people doesn't look or doesn't move like a norm, and we have to respect that. But I know it takes something of the magic out of physiotherapy. because then we're not really that special. We're just managing people. We're not managing their load to do, or sorry, the movement in any particular and nice way.
Yeah, that's right. I think quite a nice example is if we look at Usain Bolt, who probably has the flattest feet, or his planest, the flattest feet on the earth, and he's got a structural scoliosis in his spine. But you'd be a brave person if you wanted to alter those mechanics.
Yeah, yeah. That'd be quite stupid. Yeah. Sometimes my experiences working of what I've tried on my own body when I had an injured shoulder as a competitive swimmer, and what I often experience when I'm working with athletes, I don't think it's as common as it was some years ago. And what I often hear people talk is the use of passive modalities. And when we look at the Olympics right now, we've seen use of taping, and I don't know if you're into CrossFit, but the CrossFit Games has just finished. And if you look at what they're applying of passive modalities, what are your take on that, Greg? Do you dare to stick in your hand into the bees and tell us what your thoughts about passive modalities? How much is there pros and cons for those working with athletes?
Yeah, and I still do think that passive modalities are something that is in the repertoire of a lot of clinicians dealing with athletes, unfortunately. We would love to say that side of it we've moved on from that, but what I observe is certainly that a lot of passive modalities are still used, and looking at the Olympics or the CrossFit Games, you can, as I say, you can still see a lot of these passive modalities in terms of the kinesiotape. I don't think we see it as much as what we used to, but it's still very much used. And you've got to question, why are we using that? Other modalities such as cupping and dry needling and all these sort of strategies to help the athlete, so-called help the athlete, we still observe a lot. And I think, again, we need to probably put it into a couple of perspectives there. One is, if you're a clinician applying those to an athlete, are you setting up expectations in terms of what that athlete is wanting? And a lot of those passive modalities are designed to give a quick fix or a quick relief. And really, we need to question that, but also it gives the expectation to the athlete that something is able to be quickly fixed. And in most cases, a lot of the injuries that we see with athletes, it is something that we need to work on over a period of time in terms of maybe strengthening or altering things that are going to take time. And if you're applying these passive modalities that give immediate pain relief, then it may be building up a false expectation of that athlete because they're constantly wanting that. And if you're needing to do passive modalities such as massage or dry needling, or you're using kinesiotape, then you're probably not addressing the underlying problem of what's resulting in why the athletes need those or feel that they need those passive modalities. So I would take a step back and really try and look at what is the athlete presenting to you with, and what do they need to do to get over that injury, as opposed to applying something that appears to give a quick fix. I think we've got to be careful about that, because it just builds up the wrong expectations with that athlete. They're going to get disgruntled with the fact that they're not seeing the dramatic improvement continue all the time. And I think we've got to be careful if we're going down that route when you're dealing with an athlete with those passive modalities. So no, I certainly keep well away from those. I think it just builds up the wrong expectations of what the athlete wants from you as a clinician and what you can provide that athlete.
Yeah, and I think I have a few issues with that. Not with what you're saying, but with the extreme use of passive modalities, is the fact that the narrative that's built around the use of them, like, when I do this happens with your body. I mean, that's we often hear that we're putting your joints back into place. we're making your muscles do that, we are doing this with your lymph system, we're bringing out the toxics, and whatever the narrative is, which I think is another way of making them more reliant on us, but also making them think again that, oh, there's something wrong with that, so how can I perform when that is wrong?
Yeah,
And
that's
then
right.
and then there's the thing, when we look which effect it has, when people see these things applied on high level athletes, they think that what they're giving is like top of the iceberg, or what you would say, they're being given prime first line treatment, which is the best of the best. So they give that narrative on to the next patient that comes in, that they more or less seen that they can be given that, so they want that as well.
Yes, yeah, and that's, we constantly see that, and thankfully, I think if we look at the last Olympic Games compared to these Olympic Games, I think we're seeing less of those passive treatments being given, and less kinesiotape. But it's still, from my experience with working with some of the local athletes, I think we are still seeing that being provided far too much.
Yeah.
Still got to work on that one.
Yeah, also because it almost always comes parallel with that they have to back off a lot. And if there's something this population doesn't need, it's to back off, because it's not within their scope. They're used to not backing off. They're used to like doing a ton of shit of work, and now they're told to back off.
Yeah, no, that's right. And I think we all know and accept that no athlete wants to be told not to train or compete.
Yeah.
So the way that I would work with that is, if I've got an athlete that I think needs to alter their training load, it's about providing them things that they can do, as opposed to telling them what they can't do. And so approaching it from a much more positive way than a negative way. So no athlete wants to be told not to do something. No strength and conditioning trainer wants to be told that this athlete can't do certain things.
That's even worse.
And no coach does. So it's about offering them alternatives. So, there are times where we need to unload potentially their tissue that may be causing them problems, but it's about giving them options. What else can they do that can still, keep them working? So, I use, for example, a swimmer again. So it may be someone who's got a shoulder complaint. So maybe at that time, freestyle may not be the best, but they can do a lot of kick. They can use a flutterboard. They can do different things. So they're still in the pool, still exercising, but potentially not doing that one activity that's so provocative at that period of time, until things have got to the point where we can reintroduce those specific actions or movements. So I think it's really important to have that discussion with them about what activities they can do, rather than emphasizing things that they can't do so much.
Yeah, I think it's about, sometimes some of the athletes, it's about keeping them busy.
Yeah, absolutely.
Yeah. So keeping them busy and thinking, okay, if they can't do that, but when they come back to full training or full competition, we need to make sure that we've prepared them as good as we can. So they might not be skating a lot. Let's say we have an ice hockey player, because it's a lot of speed in that and provokes their pain. But if we can kind of work on their adductors and their legs in general, we would have them better prepared than telling them to back off.
Yeah.
Or
and I think if you're
could have worked on their aerobics as well, and stuff like that. So really making sure we're getting all the way around them instead of just backing off too much.
Yeah, because there'll be lots of things that you can work with that athlete if like you use the ice hockey scenario, that if you're keeping them off the ice, then providing them with other things. So working on their cardio. So could they be on a bike or an erg rower or something else like that? Could they be doing strength training in the gym? So keeping them active, as you say. And I think if you are looking at needing to alter their training, then you need to have a plan forward. they need to know where they're going and sort of roughly what timeframes are we looking at. The athlete needs to know that, the strength and conditioning trainer needs to know that, the coach needs to know that. So what is the plan forward, as opposed to just saying, right, we need to back you away from these particular activities because that's provocative and not appropriate load at the moment. What are the timeframes we're looking at? So really looking at a daily, a weekly, a monthly plan of where are we going with this altered training program, with the ultimate goal of getting them back to whatever they need to get back to. So having that training plan or treatment plan or management plan forward is really important. So then you get the buy-in from everyone involved.
Yeah, I find that's quite beneficial as well, just having a plan. And that's where they're like everybody else, right? They want a plan as well.
Yeah, that's
the
right.
ordinary guy that comes in want a plan as well. And I think we sometimes forget that. We just like, if we're working just guideline, it would be like roughly and arrogantly said, it would be like, well, everything's going to be fine. You're better in 6 to 8 weeks. And that's not a plan. That's not good practice in my perspective. But
not at all.
You need a plan.
Yep, you need to. So even if you're looking at sort of that 6 to 8 week time frame, then I would break it down into days and the week. So week 1, what are our expectations? What are we going to be looking at? And then progressing that into week 2, week 3, week 4, so they can see the direction they're going in. And that's why, we go back to that discussion that we had earlier around what have they been doing? What are they currently doing? And where are they heading? And so getting an understanding of that is really important.
And I think when we make the plan, Greg, we need to make them responsible as part of the team. Like saying, okay, I want to know what happens when we go along with this. So you're not going to see me for the next 2 to 3 weeks, but I would like you to give me a ring, shoot me an email or something like that if something goes a bit in the wrong direction, or if you have any concerns regarding if it's allowed to be painful a bit longer and stuff like that. So I think that giving them some of the responsibility, like not bringing, I don't think there's one person in charge of it, but I think they're very responsible for how the plan goes.
Yes, yeah, really important. And I think you need to also give them reasons of why you're looking at this. And it may be that you've got someone who's had a chronic Achilles tendinopathy, who on that side can only tolerate 12 single leg calf raises. And on their unaffected side, they can do 30 or 40 single leg calf raises. So you've got to demonstrate to them that we need to see strength gains in this tissue, and then once we're seeing strength and power, then we need to look at more endurance, and we need to look at explosive work, so plyometrics. So these are the things that we need to look at along the way. So they have an understanding of why they're having to do this as part of that management plan as well.
I very much agree. Greg, on a couple of occasions, you've just briefly touched about the peers and the coaches and stuff like that. How do you normally bring them into the plan with the athlete? What do you do? Do you contact them? What would you give of direction for other people working with athletes? Is it important to bring in the coaches and the peers?
Yeah, I think it's really important. So it obviously depends on the level that the athlete is, whether they're just working in isolation, if they're a weekend warrior, or if they're working with a specific coach or strength and conditioning trainer as an individual athlete, or as an athlete within a team. So all those different considerations you need to bring into it. Certainly if an athlete has a coach or a strength and conditioning trainer, I bring them in really early, because typically the coach will have a plan of what they're wanting to do with the athlete on a daily basis, as well as weekly and monthly. And so will the strength and conditioning trainer. They'll have a plan of where they're heading in terms of what they're doing with the athlete in the gym, And if you're going to then give exercises for that athlete or alter their training load, you need to be bringing those other, that network in there so that you're all working off the same page.
Yeah.
If you don't bring them in, you're not going to get that buy-in.
No.
And one, you've got to get the buy-in of the athlete, but you've got to get the buy-in of the support network as well. So
Yeah.
I would certainly bring them in at the earliest opportunity, whether that's just a phone call or whether you go down to the court or the field or the gym. I think it's really important that you bring them all in. And sort of what I talk about in terms of close the triangle. So you've got the athlete at the top, so it's athlete centered. And then you've got yourself, and you've got your strength and conditioning trainer and the coach, and you're working together as a team, all working off the same page, and having that understanding of each role and responsibility. So I'll certainly bring them in at the earliest opportunity.
Yeah, I think it's a very good idea to avoid misunderstandings, and also they also, when they work with athletes at a quite high level, they also have ambitions.
Yeah.
So their ambition is also that the athlete's going to perform, because then they've performed as well. So I think the collaboration in itself and the understanding of what we're doing is just as important with the coaches and the peers as it is with the athlete.
That's right. And I think your best results are going to come if you work as a team like that rather than working in isolation. You know, if you're working in silo and the coach doesn't know what the plan of action is, or the S&C doesn't know what's happening, then the athlete certainly won't know what's happening. So the best results that we've achieved with athletes is when you're working in that sort of collaborative approach with everyone.
Yeah. So sometimes it'd be quite difficult, despite you having a good relationship to the athlete and the clinician, when you're like, when it just takes time, Greg, when it's not over, they're not back in the game after 8 weeks or 12 weeks. Do you have any like clinical pearls or things where you go to when you have those situations, or have you already, do you know quite early, okay, this is actually gonna take you 6 or 9 months before, or I can't really predict if it's 3 months or 9 months. So how do you deal with situations like that? You get my question? I think you got a bit.
Yeah, I do, and it's a really good question, and one that is also quite difficult to answer. So I think it probably comes back to the classification that you're giving in terms of, if the athlete's coming to you with an injury, what is their classification and what are your expectations around that classification? So if we look at the McKenzie method, if we're able to classify someone that's demonstrating directional preference, then we know that should be a condition that responds relatively quickly.
Yeah.
And I'd be looking at somewhere around 4 to 5 sessions. We should expect to see significant improvement with that athlete if they're classified with a condition that demonstrates directional preference. Versus someone, if you're looking at, say, contractile dysfunction or tendinopathy, depending on the state of their presentation, will sort of dictate the timeframes that we're looking at. So if we're looking at someone with a more acute tendinopathy, so as Jill Cook and her colleagues talk about a reactive tendinopathy, then hopefully we can settle that pain response down reasonably quick and build that athlete up. So you can work on sort of timeframes around that, versus someone who's had much more of a chronic contractile dysfunction, where this may take a good result, maybe 3 months. On average, it may take 6, 9, sometimes 18 months to get on top of that. So then giving the athlete and their network that information, but also working with them that within those parameters, we can still work the athlete really hard, but we just need to be sensible about how we approach their mechanical loading. So structuring their week out, their daily routines out, so that you're not back-ending all their sudden load to, say, a Monday or a Tuesday or a Thursday or a Friday, that we actually are thinking about their weekly plan and how they are loading themselves. Or if you're doing a lot of plyometric or explosive type action one day, how is their response the following day, and giving them this sort of information. So it's a really good question, but it needs to be individualized to the athlete and probably based around the classification that that you've given the athlete in terms of their diagnosis.
And then we just know it becomes quite difficult sometimes when we can't classify them. You and I could say they have a directional preference, or they have a contractile dysfunction or a tendinopathy, which I think most of the listeners would know more about what is, or
Yes,
reactive.
yep.
Because then we have some experience with that. But if it's really like blurred, the picture, and if it really doesn't change over like 4 or 6 weeks, and you kind of already cleared by your triage, you already cleared serious pathology, and you can't really find any stresses, it seems like very load dependent, their pain, then I find it difficult sometimes, to be honest, that that we can't predict that, because it's just so nice to be the person that have the injury, and you can hear us more or less predict within a certain amount of time how long it's going to take. It's sometimes very difficult to stay an optimist.
Yes.
And you really want to navigate in being realist and optimist all the time. We do that all the time with every person we see in the clinic. And we really need to do that with the athletes, because they tend to have more of a goal, where the other goal aren't set on a date when it's just you and I that comes into the clinic. But the athlete sometimes has a goal, specific time, the Olympics every 4 years and stuff like that.
Yes, yeah, and I suppose when you're looking at what you're describing there about those ones where you're having difficulty in classifying, and it does seem to be load dependent, then I think that's the times where you need to really have a good understanding of their training and what are they doing in terms of a daily and a weekly training regime, and then correspond that to what is the athlete feeling. So are they developing pain or symptoms at a certain time, or following a certain training? Is there a threshold that they can reach that they're symptom free, but once they go over that threshold, the pain comes on? So it could be someone who's a marathon runner who says, once I get up to about 25 kilometers, then my ankle starts to hurt. Whereas in the clinic, you're assessing them and you can't find anything wrong. Or it could be a swimmer who says, after 45 minutes of swimming, my shoulder starts to get sore. Or anyone who's just sort of doing these endurance type sports, if they say that their symptoms come on after a certain period of time, then it's very difficult to try and reproduce that in the clinic itself. So it may be someone that actually you book in and see them, but you make sure that they've gone for a 20K run before you see them, and you see them literally as they walk in the door, sweaty and exhausted, and then you reassess them. So you've assessed them in the clinic and looked at their range of movement, their strength, and if they are pain-free and moving well, then assess them when they've been provoked as well. So get them to go for a run, get them to go for a swim or a cycle or anything that provokes their symptoms, and assess them at the time, and then evaluate the difference between when they were symptom-free versus when they've got their symptoms. And does that give you a bit more information? Because there may be a threshold where their symptoms come on, and you need to expose that to be able to manage them in the future. That hopefully will give you the information or the answers that you need to guide them in terms of their management.
Yeah, because I think that comes back to our curiosity as clinicians. So if we can't find anything, what have we listened to, and how can we then set the patient or the athlete in that position or situation where we might have a better chance of figuring something out?
Yeah, because I think having that baseline, even if they're symptom free, having that baseline gives you a lot of information, because when they then present with pain, you've at least had that baseline so you can reassess. So it could be someone who has an ankle complaint and they seem to move quite freely in the clinic. They can squat and single knee bend and calf raise, and then send them off for a run and they come back in, and then you find that there's a limitation in that ankle range of movement. And that could indicate that possibly they have what we call a derangement or a directional preference with particular movement within that ankle, that you do a certain movement that restores that mobility, decreases their pain. And so then you can guide them about how they manage it. So having that baseline, even if it's symptom-free, gives you a lot of information that you can then work with.
Yeah. So let's say we have an athlete, and you and I have done our exam, both the subjective and the objective exam, and we think we've covered more or less everything, but we're still at the end. We're still a bit like, okay, this client or athlete might have a directional preference based, let's say, just on your experience, because you've seen this a tons of time, but they haven't changed the symptoms at all. We're just talking directional preference. We're not talking centralization, just the directional preference. How do you explain that to an athlete that you would like to test them for the next, let's say, 72 hours, that you're not treating them, you just want to test them? You find that easy?
I'll explain to them that, as part of their sport, they're doing so many movements or repetitive movements in certain directions, and sometimes we find that moving a particular structural joint in a certain way does improve their mechanics, reduce their symptoms, and that's what we need to explore. But because of the type of sport they're doing, where they're doing so many repetitive movements as part of their sport, it may take us several days to get a good understanding of the effect of a certain movement in a certain direction. So if they're a runner and we think that they've got an ankle derangement that may respond to repeated dorsiflexion, then I'll get them to assess that dorsiflexion before they go for a run, and then let them go for that run. And then when their symptoms start to recur, get them to stop, assess that range of movement, see if there's a difference. And if there is a difficulty with that movement, get them to repeat that movement and see, does it have an effect on in terms of their symptomatic and mechanical response? Does it alleviate their symptoms so they can start running again? And get them to test it. So test the baseline, get them to test it when it's been provoked, and see what effect. And I'll explain to the athlete that our assessment may be within this clinic, but actually the assessment goes on once you're outside of this clinic, back into your normal activity and training. That's when the assessment continues. And when we next see you, that's when hopefully the information that you give to us will give us much more about how we can guide and manage in the future. So the assessment is not just what you're doing in the clinic. It actually goes on in terms of response to the exercise regime that you're giving them, or the strategies that you're giving them. So my assessments always take many days to really get a good understanding of the response to your strategies that you're giving them.
Yeah, I find many similarities in what I'm doing and what you're saying, Greg. And I also think that most of the athletes actually like this because they're getting involved.
Yes,
and they like to move, because you've gained their trust, but just by saying move and test this and see whatever happens.
Yeah, you did right. And I think athletes buy into that, because they're doing a lot of movements. Movements is their game. That's what they're employed to do. And so your strategy is based around that as well. And I think a lot of them do take that on board quite nicely.
Yeah, I think from a personal experience, I think it's sometimes teaching them to do, let's say, the specific movements before and under and after.
Yes.
So they are assessing during to see if they need to do more of it, which can keep them in the game. I think that's quite a strong tool to use, actually.
And then they can see for themselves what effect that has.
Yeah.
And if they can see that one particular exercise has this effect on them, then that's easy to get that buy-in. in terms of them doing exercise on a regular basis.
Yeah. Yeah, and the opposite would be the critique of it would be that it's too simple. But I think these people have more than enough to do just by restitution, eating, training. They don't need that we are tearing everything apart and putting heaps and tons of work into it if we can avoid it.
That's right. I think if you can show to them, and in particular with someone with directional preference, if you can show to them that there's one exercise that can have this effect on your symptoms and the way that you move, then easy to get that buy-in. Rather than giving them a whole raft of exercise on top of, as you say, everything else that they're having to do. Where I mean, a lot of athletes are really compliant in terms of building up that. Doing the exercise that you found is to be effective. But if you can have one in isolation that has the most effect, then the buy-in is going to be there.
Yeah. Greg, do you have an example of an athlete you've seen recently that you can kind of where there's some nuggets around what worked really well, and maybe you met some difficulties, or she was good or he was good at managing his symptoms based on the way you work using MDT?
Yeah, I actually had a recent case of one of our professional athletes who plays a game called netball, which is a little bit like basketball. So it's a team event. It's on a court. You've got a ball that basically you've got to get into a hoop from one end. So it's a little bit like basketball, but it's you're not allowed to dribble the ball. You've got to basically pass the ball, and people move into space and they get the ball passed to them. And you have attackers and you have defenders and you have the midcourt. And I saw this athlete, 23-year-old athlete, who was on the defense side of things. So she's having to mark her opponent and do a lot of waving of her arms to stop the ball being passed and things. And this athlete presented with a 2-day history of a cervical complaint with ridiculous symptoms into her arm, which was really affecting her ability to raise her arm. She was in significant pain. And this was during season. So I saw her on a Friday morning, and she was due to play away from the region on the Monday night. And she was a key component to this particular team. So she had had a 2-day history of neck pain, arm pain as a result of actually doing a deadlift in the gym. And had come on after that. And when I saw her on the Friday, we found in sitting that she really couldn't tolerate any repeated movements because of the level of pain she was in. So we unloaded her, lay her down with a couple of pillows, and we started doing some gentle retraction type movements into the pillow, which again were a little bit too intense. But we found that doing a lateral movement, a lateral flexion movement that she was able to achieve, actually started to get some centralization of her symptoms, so a reduction in her arm symptoms. And she was happy with that response on day one. So that was Friday. So I sent her away doing repeated lateral flexion, unloaded on a lying down with the pillow. Then I caught up with her later that day, and she had shown some further centralization. So we continued with that exercise regime, applying a bit more force. And then she was heading away the day after because they were traveling to the region that they were playing in. And we were able to keep in touch on the Saturday, the Sunday. By the Sunday, she was able to perform exercise in the sitting position, so loaded. So Sunday morning, we progressed her exercise to loaded exercise, still looking at lateral movements. By Sunday afternoon, we were able to progress to sagittal movement. By Sunday evening, she was able to move her arms above her. By Monday, we were having her, testing her in terms of team training, and she managed to play that night. So she progressed from someone on the Friday through to the Monday where we were able to fully centralize her arm symptoms and get her back doing activities above shoulder height and competing. And I only saw her on the Friday, but we were able to guide her through the use of telehealth and exercise to actually get her back to being able to play on the Monday night. And I think the beauty of that was she didn't need any hands-on treatment. She didn't need any passive modalities. She had a good understanding of what she needed to do and also the response around that particular exercise. So it was a really nice example of how someone can take control of their problem and work with them, and not needing or being dependent on someone doing hands-on treatment to them. And it was really great to see her playing on the Monday night from really, excuse me, a few days prior to being pretty miserable in terms of her position.
Yeah, yeah. I just need to clarify something. Did you just said she got injured or she got pain during a deadlift?
Yeah, she got pain.
According to social media and everywhere else, that's the holy grail of rehab. So are you actually are you trying to convince me, Greg, that you can deadlift is not all good?
Deadlifts are great. Deadlifts are fantastic, but as with anything, some people get injured with certain things. You can wake up with pain, so yeah. You can get injured lots of different ways.
No, I'm just trying to clarify. I thought the world was like pretty black and white, so it just seems like that sometimes. But yeah, thanks for clarifying. I'm a bit. It's getting late in Denmark.
Yeah, good.
Well, thanks for that story, and I think you just touched on the beauty of making them independent, and how
yes,
that
indeed.
probably can boost their self-efficacy as well. Yeah,
that's right. She knew what exercise she needed to do, what the response was to be, and how we could progress that. So it was great that she was actually away from the region, because it demonstrated the ability for her to have complete control of her sort of destiny. We just guided her along the way.
And I think you're touching on something very important there when you're saying having control, because the critique of this story could be that, well, she would have gotten better anyway. But I think the importance is that she's doing something, and that makes her feel in control.
That's right.
Compared to just not doing anything. And I think that's some of the things we misses when we say to an acute patient, athlete or non-athlete, well, everything's going to be fine. I think we sometimes miss that. We miss a ton of things, I believe. I know it's an unpopular opinion. Yeah.
That's right. Well, I mean, she had this drive that she needed to be better by the Monday evening to compete. And, on the Friday, there were certainly indicators that she was going to have a good prognosis, but at that stage, I wasn't convinced that we were going to have her right by the Monday, because she had significant arm symptoms. But by the Saturday, we started to see continued improvement, and she just continued to improve over the period of time. And it was really nice to see the progression in the management that we did, from unloaded lateral to unloaded sagittal to then unloaded lateral, loaded sagittal movements, and back into her normal training. And responded literally over a matter of 2 to 3 days.
Yeah, I think there's a few things to that. By changing position from unloaded to loaded, it also comes back to the curiosity of the clinician. How can I make this easier for the patient? How can I try to find out if she's ready to do loaded instead of unloaded, because it's easier and it might have a better effect. So not being too scared of doing too much. I think that's another key thing working with people and athletes is being curious all the time, and not being too scared of pushing and blowing into the sparks of the fire.
Yeah, that's right. And that's where we sort of gave her that education around sort of our expectation with the symptom response in terms of what effect the exercise is having, and what response were a positive and what response that maybe, okay, if this occurs, then we need to back off and maybe go back to the previous strategy. So she had a pretty good understanding of of what we're seeing. And I think part of it was because she was pretty miserable in terms of pain levels, that she was able to guide and herself pretty well in terms of those pain response.
Yeah. Great. Looking back at 30 years, which at least the last of them has been with quite a few athletes at different levels, if people want to work within this group of people, like working with athletes, do you have a few advice what they could do to get successful in that area of physiotherapy and rehabilitation?
Yeah, I think if I was a new graduate physio and I was interested in the athletic side of things, working with athletes, I think you really do need to start at a level where you're confident, maybe with the school age kids and then on to representatives, getting yourself emerged in local sport, working with different types of sport, getting to know the coaches, the local network, the strength and conditioning trainers, the massage therapists, and building up slowly, and going to events, going to trainings, getting an understanding of the different sports that you want to be involved with, starting off at that level, and slowly you'll build up the experience of working with the athletes, the experience of working in a team environment, looking at building the rapport, the network around you. That type of thing is really important, because I think if you can build up a network around you and build up that rapport with the various athletes and coaches, that's going to do really well in the future. So starting off at that level and building it up, and then just getting an understanding of what you can do. Being mindful about, we've already touched on the passive modalities, so being aware that leads to expectations from athletes and coaches, giving the athletes and coaches an understanding of what you can provide to them and how you can work with them, and being mindful about emphasizing things that you may be able to think that you're able to do. Just being humble in terms of what you're doing, listening to these sort of podcasts, reading books, looking at the likes of Bruckner and Kahn in clinical sports medicine, or the Aspetar sports journals, or British Journal of Sports Medicine, getting an understanding of all these sort of things, where a lot of these resources have gone from a lot of data specific to much more clinically orientated. So just embracing yourself in terms of all those different resources that you can get hold of. I wouldn't necessarily go into, if you're a new graduate or an early clinician, go into the higher level, because there's lots of different expectations that will be had on you at that stage. So start off gentle, small steps at a time, and build up into it. But making sure you've developed that network around you, that support network, maybe having a good mentor who's another clinician that you respect with you as well. So building up that network is really important for an early clinician, younger clinician. Yeah,
it's a bit hard line of being ambitious and realistic, and gain more and more confidence, because that would definitely do you good.
That's
when
right.
The expectations get higher.
Yep, that's right. And I think that's a really nice way of putting it, because doors will open for you if you keep on working away at it. Those opportunities will come, but sometimes it takes a bit of time to get
there. Greg, it's been an absolute pleasure talking to you about this special subject about athletes, and we talked quite a bit about humans as well, which athletes are humans, as we started to say in the beginning. So if people found you interesting, where can they find out more about you? Do you have a website? Are you in social media? Are you hiding down on your lovely island of New Zealand?
I used to be a lot more involved with the social media, but I've sort of backed away from that a little bit. lately, just because of different things. I've been doing some postgraduate university work and the work that I've been doing both in the clinic and with the Mackenzie Institute. I found that social media was a little bit too much on top of things. So I've actually backed away from a lot of the social media in the last sort of year or so. But if people do want to touch base, then certainly I'm on Twitter, Facebook, and also the Mackenzie Institute international website does have me, so people can contact me via there if they wanted to discuss anything that we've discussed. More than happy to help out any younger clinician in their aspirations and careers. So more than happy to answer any questions, but that's probably the easiest way to contact me would be via the Mackenzie Institute international website.
Okay, that's kind of you sharing your time and your knowledge. Greg, it's been an absolute pleasure, and I just want to thank you one more time for taking your time to share your thoughts and experience and ideas. And thanks to the listeners for listening at two old men with 30 and 16 years of experience.
And thanks, Brian. It's been fun talking to you.
That's good.
Keep up the good work.
Oh, thank you. You too. Have a good one.
Cheers.
Cheers.